Hello and welcome. I'd like to welcome everyone to our next episode of Complex Case Discussion Series. I'm Dr. Ryan Kazemi, and it's a pleasure having all of you with us. This is a live webinar, as you're all familiar, and of course we will have it in a recorded format and posted on our website at facialartdentalforum.com. Today, with me, I have one of my good friends who will be our expert panelist, and I'd like to make the introduction, Dr. Hugo Bonilla, and he's a prosthodontist in Annandale, Virginia. We've known each other for, I want to say, over 20 years.
Since 2001.
Yeah, I think
we founded
early days.
Millennium.
We had started an educational study club back in the days with a group of other colleagues at the Millennium. We lectured many times together. We've talked about many cases together, and it's really a pleasure to see you again.
No, thank you very much for the opportunity. It's always a pleasure to be with you, always a good friend, a fantastic surgeon, and I'm always fascinated by all the technology and how you are able to provide your knowledge and share your knowledge by social media in this environment. So thank you.
Thank you very much. Appreciate it. Now, we're both solo practitioners. So what that means is that when we have patients come and see us, a lot of times we have to think on our own feet and really don't have that opportunity to interact maybe with others. But I think it's been great to be able to share our cases, especially these complex cases, where we can kind of have a team approach and still be able to look at some of these very difficult cases and be able to learn from each other and understand what approach we're going to take, what are the treatment plans, what are the challenges. By the technology and doing Zooms and online meetings, this has become much easier. So it's an entirely different way to practice, and it's great to have that.
Yes, makes the distance a lot closer and the sharing of knowledge so much simpler. When we started with Hamid, I remember that we were into getting the fancy digital VCRs, recording surgeries, recording procedures, trying to communicate. I remember that taking intraoral photography was something basic, and then became an everyday situation to do with our patients, to share knowledge. And now when we can share a patient photo and we are both on the internet, seeing the case, seeing the radiograph, doing a brainstorm makes just such a big difference.
It's a huge difference. So let's talk about this case. Today's complex case discussion series, which I call the perfect storm for a full arch treatment failure, is a patient that we have collaborated together to some degree, and I'll explain that in just a moment. And again, our panel between myself and Hugo, we hope to dissect this case and be able to share this with our audience. Let's give the patient history. This is a patient that came to me initially having just received 6 upper dental implants and an immediate restoration, a full arch immediate restoration that was placed abroad. About 6 weeks later, he started to experience pain and swelling around pretty much all the implants. He reported some minor bleeding from the gingival tissues. And also he started to notice that the entire restoration was becoming gradually mobile. Here's a Panorex which showed 6 upper implants, a full arch restoration that looks like a zirconia, perhaps, or a metal under casting. Can you tell?
Kind of difficult to tell, especially because of the ceramics, but probably it looks like it's zirconia. Okay. Difficult to tell on the back, probably some layered porcelain on the back, but appeared that it's zirconia.
Yeah. And what I could see on the Panorex was some bone loss on the distal implants that were quite evident, but really difficult to see on the Panorex. So we take a CBCT, of course, and I think that's probably the first imaging that we need to really understand what is happening with any existing implant that may be undergoing peri-implantitis or bone loss. And so from the CBCT, we could gather that yes, there are 6 upper implants, and there was notable bone loss on the distal implants. We can actually see that quite well from this view. But then we go to the cross sections of the cone beam CT scan, and let's go through this. Implant number 5, we can see there is extensive bone loss on the buccal aspect. Number 6, the implant is somewhat sitting in air. There's not much around it, and there is this unusual radial opacity on the buccal side, which seems to be away from the implant. Number 7 is a mini implant, what it appears to be, and also some radial opacity, what appears to be some sort of a bone graft. Number 10, another mini implant with some bone material. Number 11, same thing, not much bone covering on the buccal. And number 13, also complete loss of bone on the buccal aspect as well as the periapical aspect. Close to being a sinus perforation, but not quite yet. So this patient comes to us with a loose restoration 6 weeks after it was completely placed. And has pain, has swelling,
mobility,
and mobility, and the implants look as such. What are your thoughts?
Well, first, that was a sad trip because things like this sadly look like they were made in a hurry without considering all the bone morphology, volume, length, and it's sad even when you see the bone fragments on buccal for all remaining apparent bone. It's like they broke and they are in the air. It looks like they are not even connected to any surrounding bone. The very aggressive threads on the anterior implants. You can see the cement connecting probably the abutments to the prosthesis. However, it doesn't even look like you have even abutments in there.
Right.
Sadly, it just is a sad situation for the patient.
Yeah, so obviously he's in distress. I think the treatment considerations from the first step is obviously managing his infection. The first thing we did was place him on antibiotics, and this restoration was so loose that we knew it was going to come out relatively soon. So we prepared him for just a removal of the restoration itself. The implants themselves, I was not sure whether or not they're integrated, some of them or not. I thought maybe some of the abutments or the superstructure was loose, or perhaps the implant itself, really difficult to tell. So we had this conversation, and we scheduled him fairly immediately after this visit to remove, debride, clean, at least get him out of the immediate infection and pain that he was suffering. But let's kind of talk about this a little bit. I want to give you a little bit more history about the nature of this treatment that was done. So I asked him the history of the treatment. So he went abroad. Apparently from his report, the implants were all placed. There was an immediate load protocol that was done with the prostheses that you see. There was no transitional. This was actually the final restoration and prosthesis that was delivered. And also there was some immediate bone grafting. So there was implants, bone grafting, and immediate load protocol with a final restoration in place, which is very difficult to imagine how that's done. But the reason that we know that that was the case is because he was there really for about a week, had the procedure done, had this placed, and then he was told, you're good to go. And he came back to US. So there was really no time from standpoint of his first day there to when he came back to really have a transitional restoration prepared and also a final. It was really all in one. Apparently there was a cone beam CT scan, but there was no other digital workup that was done. Again, no surgical guide and things because of the time limit that he was there. So I think, when we look at this case as a total failure, and I call it the perfect storm for failure, the perfect storm, and these are all the things that altogether, I think, led to the condition that he was experiencing. Obviously, it was inadequate bone. We can see that there was atrophy of the posterior maxilla. Certainly, there's atrophy and horizontal inadequacy in the anterior. Single-stage implant and bone grafting. This was all done in one stage, which is risky, especially with this amount of bone grafting. Poor implant selection. I couldn't really understand the rationale for doing a mini implant and a conventional implant, except the fact that there was inadequate bone, and so the mini implant was selected as an option. This was a free-handed implant placement. It was not guided. The implants had really no primary stability. They were somewhat placed outside of the maxillary envelope because there was just no bone there. Now, some of that bone loss may have been the result of the infection, but they were very poor primary stability. The bone graft that was done, interestingly enough, and we saw that in the CT scan earlier, was kind of somewhat placed outside of the maxilla and the implants. So what I gathered is that there was some sort of a tunneling technique that was done where the bone graft was placed, but it was placed supraperiosteally. And that's why we see this space between the implant and the bone graft material. There was an immediate load without a proper implant support. The prosthesis was cemented to the implants. It wasn't a screw-retained restoration. And there was significant residual cement, which I'll show you in just a moment. And of course, just the inadequate support with the type of implants we had. So I call this a perfect storm because if you want to have a failure, you have to line up all these things and do it right. And this is how you end up with a perfect storm.
Yeah. On top of that,
on top of that, the mandibular arch, I was able to restore later on the mandibular anterior teeth, but the occlusal plane is uneven. And if we add that to the perfect storm, now we're even making things worse because on top of doing an immediate loading with a very heavy prosthesis, which is a zirconia prosthesis, on top of that, in unstable implants, bone and grafted areas, and on top of that, you add that it's a very uneven occlusal plane. Mm-hmm. The forces are going everywhere. There's no control on how he bites and where he bites. Right.
It's a problem.
So